السلام عليكم جميعا. Thank you for inviting me to present this. I know الأمور بخواتيمها. Usually, once you have done everything, you have done your incision, you have done your capsulorhexis, you have done your hydrodissection, you remove the nucleus, then what remains for the patient next 10 or 15 years is how you put the IOL inside the eye. So, moving from, a disaster through some mistakes to the art of putting the best type of IOL in the best shape for the patient to remain for him to put or to give the best vision. So, how to achieve perfect implantation? Of course, a perfect capsulorhexis and a bag preparation for the IOL is very important. What's important is how you get the bag to overlap the optic in a perfect way. So proper sizing of the IOL, of the rhexis, depends on the IOL. Usually, I advise for a hydrophilic lens, probably a smaller rhexis. These lenses are much prone to prolapse post-operatively. While for hydrophobic lenses, usually the 5.5 is probably enough for a 6 millimeter optic. So, sometimes we need to enlarge the rhexis after implantation. Usually what I do when you have most of the type of 10% cataracts, usually I will do a small rhexis, I complete the surgery. I know the best thing probably for people, beginners, to enlarge the rhexis so that they can do the surgery safely. But for me, I do not like touching the rhexis once it's done on intumescent cataract. So I complete the surgery, I implant the IOL, because as Dr. Hunaim said, this bag is usually stretchable. You can put the lenses easily into a 3 or 4 millimeter rhexis. Then I can enlarge the rhexis. So it's a double rhexis technique in intumescent cataracts. If you have any rhexis extensions, of course, we obey the signs of, upfolding of these lenses. Many times we can put foldable lens if the zonules are intact, but you have to be careful when injecting these lenses. You have to be very gentle. Don't throw the lens away in an aggressive way into bags which have extensions. So if the zonules are strong, we can put a single piece foldable IOL in the bag, but if these zonules are weak, it's better to put a 3-piece IOL probably in the sulcus with optic capture. So how to achieve perfect implantation? It starts, of course, with preparing your IOL. Many IOLs now are coming preloaded, so you don't have that much effort to load these IOLs, but some of the lenses still, even if they are preloaded, you have to be careful. Probably, for example, with the Clarion IOL, sometimes the leading haptic comes straight across the cartridge, so I try to push inside, so it comes like a single piece, like the way we do it with the SA6080, for example. So correct orientation involves slow delivery. So if the haptics are stuck, sometimes we get patients, who have very high power of lenses, like 27, 28, 35, whatever. So these lenses are prone to damage the injector. But sometimes you have to be to be gentle with these types of IOLs, trying to push them gradually through the incisions, because removing these IOLs while they are stuck in the incision is damaging to the IOL itself, especially if you don't have a backup lens. If the haptic of the IOL gets stuck into the injector, as in this case, also you don't need to panic and you pull out very aggressively. No, you stop there. You can incise the cartridge using just a normal keratome. Sometimes you can use a big scissor to cut above the haptic, of course. Then you can deliver the haptic safely without damage. Many of the lenses, for people who use Technis, for example, many of the lenses, the haptics just come in a position which is called the kissing position or a stuck position. So for these cases also you have to be gentle and you have to wait to get these haptics unfolded. This is also a case in which the haptic was incarcerated into the cartridge. So sometimes you just wait, take your time, probably 20 to 30 seconds. Many of these haptics will extrude through the injector by itself. Be careful while injecting these lenses, especially with the hydrophilic lenses. Sometimes we get these lenses flipped. We are not focused a lot always. So if you are still injecting it slowly, then catching the lens in the injector, you can rotate while the lens is still being held. In a small pupil, of course, also we can this works. We can still inject lenses in a small pupil, but here you can use a Coughlin hook to make sure that the lens is inside the bag. And then in a not ideal situation, sometimes this was a patient in whom a toric lens was implanted, but unfortunately the toric lens was a very delicate lens, and the haptic was broken from one side, the optic is cut from one side, but still we did not have a backup for the lens. We just put a CTR in such cases just to prevent contracture of the bag over time, and usually those patients will behave very well in a normal manner. But still, if you very important to have very low threshold in exchanging IOLs. Once an IOL is broken, you can exchange very easily. You can use the IOL as a protection for the posterior capsule. Sometimes you get patients in whom the eye is tense. You need to remove very dense cataracts. You are afraid about, touching the posterior capsule. Don't worry, just put the lens before removing the whole nucleus, and then you can end up safely. If you have a capsular defect, still we can implant these lenses. Just 1 minute, please, if you don't mind. If you have ruptures, you can still put lenses, single-piece lenses in the back. You can convert the small PCRs into posterior capsular rexes easily, either before implanting the IOLs or after implanting the IOL. Reverse optic capture also remain very important maneuver in cases in which the posterior capsular rupture is big, and you will expect that the lens will fall inside the eye if you will not support by the anterior rexes. Sometimes disasters happen. For example, in this case, in which, especially in cases of pseudo-exfoliation, small rexes, tense eyes, then implanting especially hydrophilic lenses, in such cases, is prone to have you disaster. This eye got complete subluxation of the bag, and the whole bag was lost. So definitely you have to remove it and remove the bag, and you change into something else. At the end of the day, again, I stress the fact that be slow in preparing your lenses. Be careful while injecting these lenses, and don't be in a hurry, because this is the moment that many of unforeseen complications and very silly complications, sometimes you will see it while implanting the lens. You complete your surgery very safely, but still this is the end stage. Of course, there is something afterwards, but this is also something you have to care about. Thank you very much.
Excellent presentation, sir. I think you could be able to cover the very important take-home message you had given. The capsular exercise has to be very, very good. It has to cover the optic in the proper manner. And also, you are seeing, if you are having a small rent, I'll try to do the posterior capsular exercise. I think it's very, very fantastic presentations.
Thank you. Thank you very much.
Okay, thank you, Dr. Ammar, our mentor of Iraqi surgeon in Iraq. Thank you for your presentation.
So, for their attendance, we have a group photo behind the registration at 1 p.m. and then the time for prayer at 1:15 outside. There is a place arranged for this. So, thank you.